time to join us today. I'm your host and chair for today. My name is Ruth. I'm part of the technology team here at Health Data Research UK, helping to bring together health data through the development of infrastructure and services like the Innovation Gateway. So our theme for today's webinar is how charities across the sector are utilising and investing in the power of health data science to progress research. So our agenda for today, I'm going to give you a short warm-up and introduction before handing over to our two guest speakers, John Nolan from the BHF Data Science Centre and Fiachra Woodman from the Brain Tumour Charity. We'll then move on to a Q&A where we'll be joined by two additional panelists. Richa Sofat, she is the Breckenridge Chair of Clinical Pharmacology and Therapeutics and head of the Department of Pharmacology and Therapeutics at the University of Liverpool. She's also an Associate Director of the BHF Data Science Centre, where she leads the Enhancing Cohorts theme there. And we'll also be joined by Andrew Short from Medley. Andrew is a colleague of Fiachra's, and I'm going to leave it to him to explain the connection during his talk. So just before we begin, a few house rules. So these are our values as an organisation, and we extend these to everything that we do, including webinars. So we ask that anyone that's here today is open and positive, and that we listen to each other and appreciate different viewpoints. A few bits of housekeeping also. We are recording today's session, so it will be available to you to view afterwards. All the materials in the webinar today, including the recording and the slides, and any links we share will also be available afterwards. And if I can ask you to post any questions that you have for the panel as we go through the different talks, and if you can post them in the Q&A function rather than the chat, that would be great. Okay, so I would like to start by sharing this animation from the Association of Medical Research Charities, the AMRC, which explains how together the charity, public and industry sectors help make research happen in the UK. So hopefully this should play straight away. Yes. No. So I think there might have been some problems with sound. I can't quite see the chat, so apologies if you couldn't hear the audio, but very helpfully there were subtitles. I would, if you couldn't hear it, I would recommend going to watch it. I put there's a link underneath there. I'm really sorry if you couldn't hear it. But basically the take-home message from that video is that collaboration leads to groundbreaking research that changes people's lives, and with each sector and organisation bringing their own unique perspective. So thinking a bit more about the contribution of health and medical charities in the UK, I've got a question to ask everybody, if that's okay. I'm just going to bring up now. If you could just spend a few seconds answering this question, and then I will tell you the answer. How much did medical research charities spend on research in 2021? I'll just give everyone a few moments to participate. Couple more seconds. Amazing. Okay, it's kind of fairly evenly split between the last three. Very. Oh, a couple more people there. Okay, I'm going to end that and reveal the answer. Let me share the results. Okay. So there's a question. The answer was C, or I actually don't know if there were letters. It was the third one, the third choice, 1.5 billion. And actually it's 1.55 billion. But I think it's safe to say that funding from charities is absolutely vital for health research in the UK. These figures are from the AMRC's 2022 research expenditure breakdown and impact report, bit of a mouthful. And I've highlighted a few of their stats here just to show how some of that funding is spent across the landscape. But for a wider breakdown, you can check out the report. There's a link there at the bottom, and they've got really, there's a really digestible infographic that gives you a lot more information. So for anyone that doesn't know, Health Data Research UK is a registered charity, and to echo the animation that we watched a few slides back, collaboration is key when it comes to research and discovery, and it really is central to everything that we do as an organisation. We work with different organisations across the sector, from academia, healthcare, industry, charities, as well as with patients and the public, so that we can achieve our mission of uniting the UK's health data to enable discoveries that improve people's lives. So one of the ways that we're helping to unite health data across the UK is through the assembly and development of the necessary infrastructure and services required for research, like the Health Data Research Innovation Gateway. So the Gateway is essentially a platform to search, discover, and request access to data sets for research and innovation. And it also provides an avenue for transparency in the use of health data for research. The Gateway is delivered in partnership with the UK Health Data Alliance, and this is a network of healthcare and research organisations that come together to establish best practice tools in the ethical use of health data for research at scale. Most of the data sets that are currently listed on the Gateway come from members of the Alliance. just going to take a closer look at that now. So about 20% of Align's members are registered charities. You can see them here. Most recently, we welcomed Cancer Research UK. Some of the first charities to join were UK Biobank, Cystic Fibrosis Trust, and the Brain Tumour Charity as well. And collectively, our Charity Alliance members have added over 100 datasets to the gateway already. I'm just going to show you a couple of examples of that now. So the first one I'd like to show you is Parkinson's UK. They've added 5 datasets on the gateway so far. I've just picked out 3 here to show you that cover specialist care data, occupational health data, and patient experience data. And you can discover all of the datasets. I've just got 3 of them here via the link there on the right. I think Steph's going to put it in the chat for me. And you can click on each individual dataset to find out more about the data that's available. Things like when it was last updated, the coverage of the data, age range, what format the data is available in, the subject size, lots of different things. So the other example I've got is the Renal Association. Again, they also have 5 datasets published on the gateway so far, and I've picked out a few to show you today. They are covering disease and dialysis data, patient experience data, and COVID-19. There's a COVID-19 dataset. You can also explore these ones through the link as well, clicking through to each one to find out more about the individual datasets. And I would highly encourage you to do so, because recently we have updated the Gateway search results page. It sort of look and feel, it's a bit more intuitive and digestible. So please have a play using these links, or perhaps you can filter for a different charity and have a look at some of the other data sets from our Charity Alliance members there. So that's almost it from me before I hand over to our 2 guest speakers today. But I just wanted to highlight a couple of ways you can stay updated about the Gateway and ways to get more involved. So you can, and there's some links coming in the chat. You can create a free account on the Gateway. We have a monthly newsletter that you're very welcome to subscribe to. And we also hold these webinars, data access and discovery webinars, bi-monthly. So keep an eye on our events page to find out about the next one. And that's it from me for now. I am going to hand over to John from the BHF Data Science Centre. I'm just going to stop sharing and hand over.
Great, thanks very much, Ruth. Can I just check people can see the screen there now?
Yeah, all good.
Great. So yes, thanks, Ruth, and hi everyone. My name is John Nolan. I'm a senior health data scientist with the British Heart Foundation Data Science Centre, and today I will provide a quick introduction to the Data Science Centre and then give a bit more of an in-depth view of the health data science team that's part of the Data Science Centre, and which I'm a part of, and talk about the work that we do. So the BHF Data Science Centre is a partnership between HDR UK and the BHF. And the BHF has provided significant funding to support our work with patients, the public, NHS organisations, researchers and clinicians to enable safe and ethical use of data for research into the causes of cardiovascular disease. Our vision is to improve the cardiovascular health of the nation using the power of large-scale data and advanced analytics across the UK. So the centre has 6 key thematic areas: structured data, where we're facilitating better access to and use of nationally collated structured and coded data. Unstructured data, where we're promoting better access to unstructured data such as cardiac and brain imaging or free text and medical notes. Personal monitoring data, where we're exploring how data from apps and wearables can be linked to other health data sets to inform trajectories of cardiovascular health and disease. Computable phenotypes, hoping to develop and catalogue methods to define cardiovascular health and disease so that these can be shared and reused by researchers. Enhancing cohorts, so facilitating the linkage of existing cohorts to electronic health records to better understand causes of cardiovascular disease. Data-enabled trials, and promoting the use of routinely collected healthcare data to identify and recruit or to follow up the health of participants involved in clinical trials more efficiently. And finally, the Diabetes Data Science Catalyst, where we're extending the focus of the Data Science Centre to support research of relevance to diabetes as well as cardiovascular disease. So in these slides, I will primarily be talking about the structured data thematic area and the main project that drives the work of this team forward, which is the CVD-COVID-UK COVID Impact Consortium. CVD-COVID-UK is a project which aims to understand the relationship between COVID-19 and cardiovascular diseases. This is achieved through the analysis of de-identified, linked, pseudonymized and nationally collated healthcare data sources in trusted research environments across the 4 nations of the UK. COVID Impact is an extension of this project, which broadens the scope to look at all COVID-related research, but in this case, just using data that's available in England and the NHS Digital TRE there only. So the consortium has over 280 members as of just now, and across over 50 academic and NHS institutions. We have 90 analysts working on working on approved projects using roughly 70 data sets across 3 trusted research environments. And in terms of the data that we make available, consortium provides approved researchers with access to a really wide range of data sets across the NHS Digital TRE in England, the Scottish National Data Safe Haven in Scotland, and SAIL Data Bank for Wales. Data is available on primary and secondary care, deaths, community prescribing, hospital prescriptions, COVID-19 lab tests and vaccinations, intensive care admissions. We have disease-specific audits and maternity and mental health services data, and there are more data sets coming online all the time as well. So these data sets allow for a broad range of projects and research questions. This slide provides a quick overview of the range of projects being undertaken in our PREs. So as mentioned, most of our projects have a cardiovascular disease focus, and all are required currently to have a COVID-19 focus. We have methods-focused projects, for example, looking at recording of ethnicity in data sets and methods to minimize bias resulting from this. Medicines-focused projects, looking at repurposing medicines for the prevention and treatment of COVID-19. And then more generally, we have studies looking at the effects of COVID-19 on cardiovascular disease, on pregnancy and mental health outcomes, and many more projects. So a really wide range of research, and we have new researchers and projects joining the consortium every month. So at this stage, I'd like to introduce the Health Data Science team. So I head up the team alongside Tom Bolton. We both joined a year ago now. We have since recruited 2 more health data scientists, Merdad and Zach, who joined us in summer this year. And after another round of recruitment this summer, we've just welcomed our new early career health data scientist, Jamie Farrell, and we're about to welcome 3 more new recruits to the team in the coming weeks. The main focus of our team is to provide data management and data curation support to researchers in the CVD-COVID-UK COVID Impact Consortium to help them to plan, conduct and complete their approved projects. So at this stage, I thought it would be useful to describe what we mean by data curation, and in particular the data curation pipeline. So by this, we mean the process of transforming the range of data sets that are required for a project into a set of analysis-ready data that has been designed to answer a specific research question. This is something that all researchers and projects will need to do. This process typically involves data management, data wrangling, data cleaning, harmonization, and we try to code this up with an emphasis on inbuilt checks. The typical stages of a data creation pipeline might be things like cohort selection, identifying key patient characteristics, and then using code lists to identify covariates, exposures, and outcomes for all patients in the study cohort. In terms of motivation for our team, this is a quote from the Goldacre report earlier this year, where it's estimated that 80% of the work on data science projects with NHS records is spent on this type of data preparation for analysis. So this is a big motivation for our team to accelerate research by reducing the amount of time taken for researchers to get to the analysis phase of their projects. We aim to do this by developing resources to help researchers understand and to use the data sets in the TREs, and we divide these resources into data and code. So, for example, data notes. We want to provide data notes for each data set that we make available, which summarize the key need-to-know information. And I've got an example for our GDPR, our primary care data in England, on screen here. These notes will provide in-depth descriptions of the key features that users need to be aware of when working with the data. And we can also add links to external content, point users to summaries and data insight analyses and notebooks that have been carried out within the TREs, and to code to produce curated versions of these data sets within the TRE. We want to provide data dictionaries that provide a single source of information for all the variables across all the data sets, along with the variable descriptions, formats, and the lists of associated values that they can take. And this is not something that was available just off the shelf to researchers. They were frequently having to go to multiple different locations to find this type of information about the data. For the NHS Digital TRE for England, we have worked alongside their data wrangler team to develop data summary notebooks, which provide for each data set batch and variable summaries, data coverage plots to show the time period covered by each data set and to allow researchers to assess when data is complete to, variable completeness summaries, which show how this has changed across batches and to identify any issues that arise with the data, and linkage metrics to show how each data set overlaps and links to each of the other data sets in the TRE. And we're aiming to extend these data summary notebooks across all the TREs. So we also have data insight notebooks, and by this we mean data set specific analyses that are essentially explorations of the data that help us to better understand the data sets and which can then be shared with researchers via notebooks in the TRE. This allows researchers to see the results of the analysis, but also the code that produces it, which might be of use for their studies. So for example, on screen here, we're investigating the completeness of diagnostic and procedure coding and outpatients data, and then looking at the number of outpatient records by ICD and OPCS4 chapters. Or for our primary care data in England, looking at the data coverage, not as an overall data set, but for the different types of codes that are recorded in primary care. So by doing this, we can see that the diagnostic coding on screen here, we have data stretching back to the early 90s, providing long disease histories, but that for prescriptions and measurement codes for blood pressure and cholesterol, etc., we only have data going back to mid-2018. For researchers who want to use primary care data to identify a population cohort, we can explore how the volume of IDs in our data compares to the published GP list size or to ONS population estimates. and then explore and explain the reasons for the differences between these two researchers. In terms of code resources, we support researchers by providing generic and specific and project-specific demos, which provide researchers with example code showing how to carry out kinds of data management and manipulation steps that they are likely to use in their projects. So researchers might need code in a new language in the TREs. For example, a researcher with a data background who then needs to write SQL or Python code for their data curation pipeline in the TRE for England. So we can provide code demos to show example code for things like connecting to required dataset tables, reading in data, selecting required variables and creating new derived variables, joining datasets and grouping and summarizing data. We can also create dashboards within the TRE to allow researchers to explore things like data coverage of datasets themselves and to identify suitable sensor days for their project and their analyses. We also aim to provide code that allows users to create cleaned, streamlined, practical, and easy to use versions of each data set. So for example, on screen for hospital admissions data, reshaping the ICD-10 coded fields from wide to long format to facilitate easier code matching, standardizing variables, variable names and formats to help combine and integrate with other data sets, and finally cleaning code fields to remove things like trailing white space or additional characters to ensure that all the correct code matches are made. There's lots more examples I could provide here for curated data, for example, removing duplicate records from death registry data, or applying data cleaning rules to vaccinations data sets to ensure that it has been cleaned and formatted consistently with what has been done in other TREs. Finally, data curation pipelines. An example is the function that we use to derive key patient characteristics, such as sex, year and month of birth, ethnicity, and LSOA across multiple data sources. This is something that all projects will be required to do as part of the pipeline. The function selects the columns of interest from the primary care, hospital, and death records, and then harmonizes and binds these records together before applying a set of rules to form a single record for each patient. This function has an emphasis on inbuilt checks, where we allow users to check the data by looking at which sources each of the patient characteristics are being identified from and how far back is being looked to find this information. Another example is code that we have written to match project code lists to patients' hospital, primary care, prescribing and death records to identify covariates, outcomes and exposures. Again, we've written this code to provide plots to show the distribution of patients over time for each individual covariate or outcome, and to show which sources patients are being identified from. And in this example, we can see that for depression, cases have largely been identified from the primary care records, while both diabetes and hypertension are being primarily picked up from primary care dispensed records. Again, code also produces output tables which summarize which sources cases are being identified from for each covariate or outcome, and a summary showing that the number of records and patients identified by each individual code. And this is something that we think is really important for researchers to check to ensure that code lists are behaving as expected, and particularly for researchers working across multiple TREs. These outputs can be compared to ensure that they're getting consistent results across the TREs, and if not, that this way we can flag up things that might need to be explored and potentially corrected with code lists or code itself. So finally, an ongoing part of our work is obviously providing direct support to researchers and projects. So this can mean reviewing project proposals, assessing their feasibility prior to approval, and making sure they're feasible with the data sets that we have. And this is something that is becoming much easier and quicker to do over time as the resources and knowledge we build on our data sets increases. We also aim to meet with all new researchers to understand their project requirements and, where possible, signpost them to relevant documentation and coding resources, code demos and any off-the-shelf code that we might be able to adapt and use as part of their project. The level of support we provide varies from project to project, so sometimes it's just signposting researchers to these resources, but sometimes we also take a lead on the development of the data curation pipeline. And a typical pipeline, as mentioned earlier, might include these stages: setting parameters, cohort selection, identifying key patient characteristics, and identifying various exposures and outcomes, and tends to result in something like this, where you have 15 separate scripts that are just for the data preparation phase of the project. As we complete more projects and produce a better understanding of the data we hold and increasing amounts of ready-to-use data curation code, we expect that this process of building a data curation pipeline will become much quicker and much easier to complete. So I will stop there. Hopefully that's been a useful introduction to the BHF Data Science Centre and to the work of the Health Data Science team. Thank you very much for listening, and I'll hand back to Ruth. Thank you.
Thanks so much, John. That was... Oh, I'm having problems with my sound. Can you tell? Can everybody hear me okay? Yeah, perfect. Thank you so much. That was really good. We've had quite a few great questions in the Q&A, but we'll save those for the session at the end. So I'm now going to hand over to Fiachra for our second guest speaker today.
Thank you very much, Ruth, and good morning to everybody. And a big thank you to HDR UK to give us this opportunity to talk to everybody. I'm just going to share screen and just check that people can see a slide okay.
Yeah, all good.
Good, thank you. So my name is Fiachra. I joined the Brain Tumour Charity as their CTO back in 2019 to build something called Brian. And I'm going to talk a little bit about Brian, predominantly as context to give a background to the product that we've just built called Medley. Brian is something that we built for the Brain Tumour Charity community, and it stands for Brain Tumour Information and Analysis Network. It's an app and it's a web app. And we built it because we wanted to be able to create an environment where people could share information with each other to make better informed decisions about their own healthcare. We also wanted to be able to commingle PROMS data, patient-reported outcome measures, gathered from patients and carers with national data sets. So we have in excess of 20 million rows from NHS Digital relating to the 150,000 people who've had brain tumours in England over the course of the last 11 years. We have a roughly equivalent data set from Public Health England as well. And we also have access to the SAIL database in Wales and aggregated data from Northern Ireland and Scotland. And certainly all the comments that John has made in respect to the challenges in terms of doing the data curation, working with the HES data set, really does resonate. But with that comes the responsibility of getting that data into the hands of people who can use it. And so we have built, I think, in excess of 45 online interactive insights in Brian that people can use to look for information on brain tumours in the UK. Brian, by the way, is free to everybody, so please do go use those facilities. If you're not finding something you want, please tell us, and we'll do everything we possibly can to facilitate that. Third reason we built Brian was that we wanted to be able to create an environment where people could store their treatments, their appointments, their medications, their symptoms, their side effects in all in one safe, secure place. And to get away from that sort of challenge of having that LibreArch file available, everywhere people go. And then finally, we wanted to be a point of data dissemination for others because we realized how hard it was to get the data that we got. And we never wanted data access to ever again be an impediment to people being willing to do research in this area. So that was Brian. Brian's got about 9,000 users using it now. As I say, it's an app and it's a web app. It's building up a good body of data. It got an ORCA score of 92%. We've gone through an NHS digital audit, which was a wonderful experience. It was actually really good for us to go through that experience, and we came out with the best score that we could get. But we were given an opportunity to present Brian at an AMRC Life Art meeting, and it was great. Brian was very, very well received. But the resounding challenge I heard back at that meeting was, this is great, but can we please stop reinventing the wheel? Can we please find a way to use these technologies that you built in other disease areas? Because, at the end of the day, money for rare diseases is in of itself rare. And so we need to find a way to do that. So that was the kind of the challenge that we were left with. And you know, it's a significant challenge for a charity of our size to contemplate the prospect of building a solution that would actually work across multiple therapeutic areas. You know, we would want to be able to create an app that allowed, you know, a patient, for example, to manage multiple conditions within a single app. We would want to be able to get national data sets across all therapeutic areas. So it was a significant challenge, but we did decide to grapple with it. And we did it because we believed that there was an opportunity to build a bridge between two fairly disparate entities who we felt actually had pretty mutually compatible goals. You know, patients at the end of the day, you know, they want a cure, they want a better quality of life, they want early access to medications, they want early access to clinical trials. Charities need data and to inform their strategies and to help them champion the causes of the communities they represent in terms of pathways and protocols and procedures. And carers want to do a better job for the patients that they're looking after. Meanwhile, we know that researchers need the data that is available to find those groundbreaking insights. And increasingly, sponsors, life science companies need access to real world data to support their MHRA applications, to fill out their HTAs as part and parcel of their submissions for, you know, nice reimbursement negotiations, etc. So it just felt like there was two disparate entities that we could build a bridge between. So we came up with this proposition. And the proposition basically is that we have charities who will sign up to the Medley SaaS platform. And by virtue of so doing, we will then put in the hands of those charities an app that has their look and feel and colors, etc., which they in turn can put in the hands of their patients and carers that are affiliated to their charity, that allow them to gather PROMS data by the Medley app and the Medley web app. Meanwhile, we'll go and get national data sets on behalf of those charities and provide them with an analytics environment that allows them to analyze those national data sets and to analyze that PROMS data. And then we will share that data out as anonymized aggregated insights out to sharers, to researchers, but also then monetizing it out to life science companies, hopefully generating a revenue share that comes back into those charities that's commensurate with the data contribution that's made by their community. Now, this is Medley on a page, and there is far too much on that to hope to go through that in this session. But what I did want to do was jump in and take a little look at the software to see how that works, to see how a charity, an org admin working for a charity, or indeed a registry or any academic team, could use something like Medley to actually customize and tailor the app to be what they want it to be at any given time for their community, to gather the information that they need from their community, and indeed to share the information that they want to share with their community. So I'm going to now flip across and look at the Medley app. So hopefully you can see my app on screen. Andrew, if I can get a thumbs up from you if you can see that, that's great. Thank you for that. So this is the Medley app, and this is what it would look like as you download it from the App Store. And there's 3 points of navigation on that screen. And forgive me, I'm just having to move some Zoom controls out of the way so I can see what I'm doing here. So on the bottom of the screen, you've got that bottom nav, and you've got the home screen, which gives a nice summary of what's happening for somebody, a schedule that gives a summary of what's going on any given day. You've got trackers that people can use, create their own trackers, use charity trackers to record how things are going for them. There's a navigator, which I'll touch on briefly later. Then there's also a more screen that gives access to various of the features within the app, such as summaries of appointments and medications, access to questionnaires, discussion boards, news feeds, clinical trial finder, benefits finder, etc. And then the third point of navigation is that burger menu on the top left-hand side of the screen, which I would kind of describe as, well, the left-hand nav containing predominantly housekeeping features, apart from one element of here called affiliations. And affiliations allows me as a patient who's downloaded the app to affiliate to a particular charity. And in this case, what I'm going to do is affiliate to HDR UK. And I just set up HDR UK in the back end this morning. So HDR UK are going to have to forgive me if my styling of the app isn't quite in accordance with what their brand guidelines, and I'm sure they'll forgive me that. But now you can see that by virtue of affiliating on to HDR UK as a patient, and it could be the Brain Tumour Charity, it could be any other charity, the app takes on the look and feel of that charity with whom I've affiliated. And, you know, the home screen and the schedules and trackers, etc., all look like now they've been branded to be HDR UK. Okay, so that's sort of at a high level what we do in terms of allowing patients to affiliate out to charities. What I then want to do is flip across to the web app. And as I mentioned, Medley is both a platform and an app and a web app. And this is me now looking at the web app screen that would be used by an org admin working for a charity to start to tailor the app a bit more to what I want to be able to do. So for example, here, I might want to be able to set up a newsfeed within the app. I might call that the HDR UK newsfeed. And I've actually got, I've just put in a URL there to a newsfeed, and we'll go and take a look at that in a minute. Then a couple of other things I might want to be able to do. I might want to be able to set up a tracker for my community, information that I want to gather from those people on a day-to-day basis. And in the interest of saving a bit of time, I have set up one in advance. And you can see here that on my tracker, I'm going to ask these people a number of questions about how they're feeling cognitively, how they're feeling physically, etc. And I'm going to go in and add a new item in here. And you can see here then the various UI elements that I can use to elicit the information that I want from my community via my tracker. Here I'm going to set up one called a slider. And the question is going to be, how is your sleep? And after that, I might say that I want the minimum value on that slider to be 1, the maximum value to be 10, the step to be 1. I might want the colors to change so that it kind of goes from gray up to green as the value of the slider changes. Then I might also put labels in on those values. So I might have minimum value of poor, mid value of okay, a high value of great. And then I might also want to show value indicators, and I might also want to show tick marks, and I might actually want to elect to have that slider show horizontally. And I'll save and close that. So now I've actually seen my how is your sleep question appear at the bottom. I actually wanted to be with the other slider, so I'm going to move it up there. And then I'm also going to go in and test and preview that just to make sure it looks okay. So here's the HDR UK tracker we're just creating. And here's the question we just added on sleep. And I, as the org admin, can just check that all looks okay before I decide to publish that out to my community. I'm just interacting with various sliders, deciding which charities I'm affiliated with, and then maybe interacting with that ranking question. So it just gives you a flavor of some of the UI elements that are available to actually do that. I can also then set up an insight that I want to have as part and parcel of this, and I can just add that question we just added in called how's your sleep. And I'll just give that a label as well. And then I can layer on medications and appointments on that, see a preview of the insight. That looks okay to me, so I'm going to save that. And then I'm going to elect to publish it. All right, so I'm going to publish that tracker. One other thing before we go back and look at those things appearing in the app, I'll also take a quick look at Questionnaire Builder. Now, Questionnaire Builder is a little bit like Tracker. We've tried to make it look really like Tracker on the basis that if you know how to use Tracker, you know how to use Questionnaire Builder. But there's a lot more logic and functionality built into the questionnaire. Again, this is built. This is based on the EQ5D questionnaire because I know they're pretty stringent in how you actually present that. So if we could do EQ5D in here, we could do most questionnaires. Here I'm going to add an item again. Here I'm going to add an image, and I'm going to call this image HDR UK, and I'm going to upload that image from their folder. There, if I can see the screen, that'd be great. And then save and close that. And so I've added that additional image in, but it's all the way down the bottom. So I'm just going to drag that up to the top here. Whoops, sorry about that. And then I'm going to go in and test that, just say, make sure I'm happy with that. So I've got an EQ5D questionnaire there that's got HDR UK on it. And I can start to interact with that to make sure that all the questions look okay. That looks fine to me. So I'm going to cancel out of that. And I will remember to publish that as well. Okay, so now I'm going to flip across and be a sysadmin working for HDR UK. Sorry for Medley, I beg your pardon. I need to log in again. And I'm going down to the admin control panel. And I'm going down into questionnaire approval. And I've seen that a questionnaire come in from HDR UK, which I'm going to approve. And then I'm also then going to go to the admin dashboard again to look at tracker approvals. And I've seen one come in from HDR UK there as well, and I'll approve that as well. Okay. And now I'm going to flip back to take a look at the app. Okay. So the first thing I think we did was put in a news feed. So I'm going to go to the more screen and go down to where the news feed is. And here you can see the HDR UK newsfeed that we had it in, yeah? And then if I go across to trackers, or if I go across to schedule, and I can see now I've got a HTT4 tracker that I can interact with. So if I touch on that button, I'm brought straight into the HDR UK tracker, and then I can start to interact with those questions that I specified when I actually created the tracker in the back end. Okay, and we've been able to do this without needing to rewrite anything, recompile anything, re-release anything. We're actually just managing to get these new features via the feature builders in the platform live in the app pretty much in real time. Okay, and then the other thing I think that we added on was a questionnaire as well. So here you can see this new HDQ4 questionnaire in here as well. Again, I can start to get my users to interact with that for me. Okay, so that was just some of the feature builders in Medley, which are being brought into the app. A few more that I thought I would look at really quickly on the hope that we do have time. I was going to show you how we use Navigator. But then when I looked at it this morning, I thought it's too complicated to do this online. So I thought I'd just use a slide for doing it. And Navigator basically is a tool that charities can use to give their community context-sensitive help. So the charity will use the web app, the platform, to go in and identify the stages associated with their disease area. And then they will identify each one of the steps within each one of those stages. And then they can write content under the guise of questions, actions, resources, etc. And then decide that and create a version of the content for adults and a version of the content for teens, etc. And they actually populate that all into the platform. And then by virtue of actually being affiliated with that charity, I can then go into the Navigator. I can select the HDR UK Navigator, and now I, as the patient, can answer just 2 questions. And the answers to those 2 questions effectively becomes my declaration of where I am in my pathway. So I might say that I'm having treatment, that's the first question, and then I'm having radiotherapy, let's say that's the second one. And now, thereafter, when I look at what should happen, all that is relevant, all that's context sensitive, relevant to where I've said that I am in my pathway. And I can go in and mark things as having been taken care of, or I can go in and mark things as bookmarked, things I want to go back and take a look at later on. Equally so, very, very briefly, just looking at some of the other features that are in the app that are less dependent on what we do in the back end. If I go back into go back into schedule, if I hit that plus button, I've got a very quick way of adding in appointments and medications, okay, really quickly. Equally so, if I go into trackers, I can go into symptoms, and I can mark what symptoms I have today and the severity of those symptoms. I can add new symptoms in, and I can use a body map if I want to, just to drill into where that symptom might be. And I might say I got shoulder swelling, specify severity against that, save that, and I've got all that done. So that's some of the things I wanted to show you. Likewise in trackers, if I go in there are user trackers in there. I can create my own trackers, so I can go and actually decide to record what my own blood pressure is, etc. by that tracker. And I can also then go in and look at insights associated with that. So I could look at my blood pressure over time to see what's going on within the app as well. And equally so, I can go into trackers and look at wearable trackers as well. There's also discussion boards in there as well. So there's a whole raft of different features in the app that we built into Medley. So as I say, that's kind of Medley on a page. We haven't looked at the analytics environment at all, but there is an analytics environment that allows people to start to analyze that data, the national data sets and the PROMS data sets as well. But it was just a little bit too much to cover off on this in this session. I'm going to hand over to Andrew now, who has just joined us, and Andrew, over to you.
Excellent. Thanks, Fiachra. I appreciate the comprehensive summary of what we're doing. And firstly, lovely to meet everybody, and thank you to HDR for inviting me onto the webinar. Just building on everything Fiachra's just said. So I joined the organization late summer. I come from an integration technology background, and I was really excited when I found out about the opportunity for Medley in terms of what it's doing in the marketplace. I firmly believe that there's so much market opportunity out there for what we're doing, and everything we're doing is geared around improving patient health and accelerating change. I'm under no illusions that the health system as a whole is a very complex beast in terms of change, and what we're doing is we're putting ourselves firmly in the center of that change and that transformational change, and bringing together the various vested parties that are involved in that sector. And so key for what I'm doing right now is head down on executing our go-to-market strategy, and the cornerstone of that right now is, as Fiachra has alluded to, is to build out and replicate what we've done with the Brain Tumour Charity. That's very much the blueprint of what we're doing, but taking that message into net new charities to bring them onto the Medley platform. But in parallel to that, now looking to broaden out into the life sciences and the pharmaceuticals and the med techs and the health techs of this world to bring them on to our vision of what we're trying to do. Incredibly exciting about the market opportunity. And I think, you know, we're in a really good place. And I know we have some time set aside from the end of this particular segment, but I'll be more than happy to fill questions offline if anyone's keen to understand more about what we're doing. My email address is on the screen, but yeah, super exciting, and look forward to working with some of you in the future.
Wonderful, thank you, Andrew. You know what, we probably have a couple of minutes to spare, Ruth, if that's okay, because there's just one other feature that I would have wanted to show people if we could. One of them was this is the nudge builder, because we all know that these apps can fall into disuse. And what the nudge builder allows a charity or a registry or academic team to do is to create a cohort of users, and then to figure out what's the next best action for those cohort to do. So, for example, they might be inputting appointments, but not inputting medications. They might be putting in medications, but not putting in reminders. And so what we can do then is use this nudge builder to actually create a series of effectively push notifications to nudge that cohort to do the next thing that's most applicable to them. And so, for example, if we'll just look at an example here, 30-day absence, if I go in and edit that one, I can see that there's a message that's going to come out and a push notification says, hi, you know, we haven't seen you for a while. Let us know how things are going via our charity tracker. And the name of the nudge is 30-day absence. And what we're doing here is we've got a push notification, which is going to bring somebody into the charity tracker index. And the rule is that we haven't actually seen any activity in terms of app opens within the last 30 days. Okay, and so if I then just want to test that one, again, I can send that to Tina, who have logged into us on the app. And if I then flip across to the app, you can then see that notification arriving, and I can then hit on that, and that will bring me into that particular tracker. Or alternatively, I could go in and look at maybe this one, which makes a bit more use of cohorts. Here, what this is about is sending a push notification out saying, please provide your CHI number. So I might have decided that I want to be able to link my PROMS data to my HES data. And in order to be able to do that, I might need to get national NHS IDs from people. And of course, the Scottish equivalent there is going to be CHI numbers. So here I can build a cohort, and I can then go in and select cohort, which I've pre-created, called Scottish patients. And here I can use, you know, the counties to identify those people who are living in Scotland. And after that, then I can send out a push notification that's going to bring them to the About You page. And the rule associated with that is going to be that if you have an About You field called National Health ID, which is incomplete. And then if I go in and test that one, I can hit that again, send it to Tina just to make sure it's right before published to the whole cohort. And if I then flick across to the app again, I can see that request coming in as a push notification to that user saying, please go and actually provide your CHI number. And if I do that, I'm brought into the page where I can actually go in and add my NHS number, which of course in this case will be a CHI number. So just wanted to show you how those nudges work as well. There's lots and lots of features in there. We can't cover them all, but I just wanted to show you nudges as well because I thought it was quite important. I will stop now, Ruth.
Oh, no, don't worry. It's really interesting. Thank you so much. Thank you both for brilliant talks. We're now going to take a look at some of the questions. But if I can just ask all of our panel members to turn their cameras on, and we've been joined by some extra guests. So I'd just like to take a moment to for each of you to introduce yourselves, and I'm just going to do it in the order that I see you. So Fiachra, really quickly, do you just want to give a brief hello again?
Sorry, forgive me.
Or a wave. Just give a wave.
No, sorry. Yeah, no, sorry, no apologies. Sorry, here.
And then Andrew, you're next.
Yep. Hi, Andrew Short, Medley, Managing Director.
Thank you. And welcome, Angela. Do you want to just briefly introduce yourself?
Yeah, hi, good morning, everyone. So I'm Angela Wood. I'm a Professor of Health Data Science at the University of Cambridge, but also an Associate Director of the Structured Data theme with the BHF Data Science Centre.
Thank you so much. And Richa, would you like to introduce yourself as well?
Hi, everyone. My name is Richa Soford. I'm a Professor of Clinical Pharmacology at the University of Liverpool, and I'm also an Associate Director at the BHF Data Science Centre leading the cohorts theme.
Amazing. Thank you so much. And of course, we've got John, give us another wave. Thank you so much. So we've got quite a few questions in the chat, some of which have been answered already. But just to kick things off, I would like to start with a question to John and team, if that's okay. So your talk very much focused on the structured data theme and the impacts, the COVID consortium, but I wonder how the team are supporting the other themes across the BHF Data Science Centre.
Sure, thanks, Ruth. And yeah, I think it's definitely true that the real focus of our work the past year has been on that structured data theme and supporting researchers on their projects in the consortium. But I see that changing going forward. So a lot of the themes, so for example, Reach's cohorts theme and data-enabled trials and the personal monitoring data, all of these themes want to essentially link their own focus data sets to the routinely collected electronic healthcare records that we primarily work with. So the way I see it is that all of the resources and the code and the knowledge that we're building up will ultimately be put to good use in supporting those thematic areas. For example, we are already supporting the work of the Diabetes Data Science Catalyst, because that's largely equivalent work. It's essentially diabetes focused research instead of cardiovascular disease focused, but it's all taking place in the same TRE with largely the same data sets. So we're already supporting that thematic area. And then the other area that we're supporting that I wanted to highlight was also the computable phenotypes. A lot of this work requires exploration of the more novel data sets that we've got, so disease registries that many of our users won't have used before. So there's a real overlap in us understanding these data sets and identifying what's possible with them in terms of developing phenotypes that researchers can use. And all of that work will feed into benefiting our researchers, but also drive forward the work of the phenotypes thematic area. So I think as we go forward, there'll be more and more application of our work across the themes of the Data Science Centre.
Amazing, thank you. Angela or Richa, would you like to comment on anything there?
I've got nothing to add, maybe Richa.
No, nothing. I think John's covered it all, unless there's.
All right, thank you. Okay, I'm just taking a look through some of the questions that have come in. We've got quite a few about the Brian app. Is the Brian app being used to collate symptoms, and is this being fed back into symptom awareness for earlier diagnosis?
Yeah, so I mentioned, I think, forgive me if I didn't mention it, but I think one of the ones that we haven't really cracked on the Brian side was the fourth reason why we built Brian, and that was to actually be a point of data dissemination ourselves. And I've made a note to myself to find out from our own internal data science team what we're doing in terms of using the HDR UK gateway, because that might help us crack that one. But yeah, within Brian, people can go in and record their symptoms, the severity of those symptoms via that very, very fast quality of life check-in. And we're then gathering that data within Brian and are very keen to make that accessible to researchers. There are 4 challenges, by the way, in Brian. There's a selfie challenge, a speech challenge, a snap challenge, and a stability challenge. These are all things that people can do within the app. And they are all being fed into a study being run by Matt Williams and Imperial. And so we are taking the data we're gathering in Brian and feeding it into studies as best we can. And want to do more of that.
Brilliant, thank you. Another quick question. Which charities are involved to date with the Brian app?
So Brian was built by the Brain Tumour Charity exclusively. So Brian is the kind of forerunner to Medley. Medley, the product build has just been completed, and we are about to launch with a partner in Medley. I don't, Andrew may know the answer to this one, forgive me, I don't, whether or not that's out in the public domain or not, or whether we have to hold that under wraps for now. I suspect it's the latter.
Yeah, I think, yeah, Yeah, I think that we're literally about to go live with a particular partner, and more details will be coming out there in the coming weeks. So yeah, but we are connected and talking to multiple charities right now across a wide range of therapeutic areas. But more than happy to share more information as we can. And I did see one particular question on the chat about the website that is literally about to go live in the coming days. So that would be at medleyhealth.com. And more than happy to field more questions offline about what we're doing.
And can I just add one other thing on Ruth? The video that you showed at the start, Ruth, couldn't have teed this up any better. It was just that
yeah, it was perfect.
Charities,
if you could hear it.
No, but we got it. We all got it. But it was that collaboration, that all-important collaboration between patients and charities and researchers and life science companies. And if we could just get out of our own way a wee bit, then we potentially could actually drive a much more open and worthwhile dialogue. So I thought it teed it up perfectly.
Yeah.
Oh, thank you. Next one to work on the audio, right? I wonder as well, so quite a few of the questions from John's talk have been answered already, but I wonder if we could expand on some of them. I'm just looking at them now. Oh, no audio. Oh, there it was. How can patients and the public find out about how their data are being used by the British Heart Foundation? How can they find out about data security, data governance? Are there any relevant links on your website? Angela's very kindly put some links, but I wonder if we could expand a bit on the sort of patient and public awareness of data governance and what's going on and what you're doing in that area.
So yeah, I can have a go at answering that question. It's definitely not my area, but I do know that all of our projects, for example, before being approved, are put before the Approvals and Oversight Board, which has membership and a representation of the public on that panel, and that they're there to make sure that the scope of the project is suitable and to provide feedback on the areas being addressed by the project, and they have the opportunity obviously to reject or suggest amendments to the project. So that's the main way I'm aware of that PPI is kind of built into the process certainly for CVD-COVID-UK.
Yeah, there's some helpful links there as well, which we will share afterwards. Another question from me, if I may, sort of coming from two angles really. When you're working with researchers inside the trusted research environments, what are the most frequent challenges that crop up when it comes to accessing the data and then using it for research? It would be nice to hear sort of the perspective from the data curation side and also the perspective from how it's being used in research now. There's sort of common ground between the two.
So in terms of accessing the data, I think certainly the consortium has made that a lot easier. It is a much more streamlined and slick process to apply to get access to this amazing breadth and wealth of data. In terms of the challenges and sort of issues that researchers then face when they are approved and arrive in the TRE, I think there's probably two separate types of challenges. There's the sort of environment and coding challenges. So working in TREs can be quite restrictive in terms of the tools that are available. So I think, as I mentioned in my slides, that people frequently might have to learn a new software in order to be able to work with the data, particularly in the case of England, where the volumes of data are so vast that you're forced down a kind of Python, PySpark coding route in order to be able to harness the power of and the volume of the data. There's then, I would say, the other side, which is the challenges that I'm sure everyone working with healthcare data is familiar with, which is finding the right documentation, which our team is obviously trying to help with, but also really understanding the features of these data sets. So I focus on primary care in my slides. This is a very straightforward looking data set, one table, codes, dates, IDs, but there's a lot of things that users need to be aware about it that can be kind of hidden in terms of the inclusion, exclusion criteria and what codes are available, what the sort of history provided for patients is, how opt-outs affect it, how the ID linkage system affects the data. All of these things are things that researchers need to be aware of, and there's some sort of potentials for people to trip up if they're not aware of these things. So again, I think that's another challenge. How we go about addressing that, obviously we're trying to prioritise the frequently used data sets and to understand all of these, but we've got 70 data sets, and I should emphasise that everything I've talked about today is work in progress, and we're trying to roll this out across 3 TREs and an awful lot of data while trying to support projects and prioritise the most frequently used data sets.
I wonder, that's so great, thank you, John. I wonder if Rita and Angela, you would like to give a slightly different perspective in terms of how the data is being used across the sort of the thematic areas that you're both covering, and if there's any sort of challenges that are different, or if they are aligning to the sort of the curation side as well.
So I guess from a scientific point of view, you can't answer every question using routinely collected data, but it can answer some great questions, and it can answer them really, really well. And I think what we're trying to focus is definitely on those questions. Questions about causality becomes really complicated in routinely collected data. Trying to adjust for confounders when there's lots of missing data becomes incredibly challenging. So there are limitations with regards to the scientific question you can answer. Richa, I think, has done brilliant work on using medications data set, where I think there's even, you know, I admire you for doing that, because I think you really kind of utilize the strength of that data. So maybe you want to say more about that.
Yeah, I can do, and then pick up actually on the cohorts as well, which I think relates to what Angela's just said. So I think you're being too kind, Angela. I think the medicines data is probably easier than the disease data, because there's an element of hard coding, whereas, you know, diseases and phenotypes and the computable phenotypes, which John mentioned as well, is sometimes a little bit more tricky and open to interpretation. But I guess it is, I think the value of the data in this way is it's the first time that you have been able to link multiple data sets within the routine sphere to be able to ask questions and actually get answers. It was always on our wish list to be able to do that, but now you can actually do that. And thanks to the efforts of John, Tom, Angela and the team, actually that curation piece has almost accelerated work that would otherwise take a really, really long time. So it's really valuable curation work that is going on. And just coming back to what Angela said, you know, you're absolutely right. Routine health data can't answer all of your questions, which is why the enhancing cohorts theme is exactly about that. It's enhancing cohorts with routine data, but actually when you've got cohort data, which might have other elements of bespoke clinical data, genomic data, imaging, wearables, and it's really interesting to hear about the app actually, it links in quite nicely, then actually how can you enhance all of that information to build a really rich data set and do multimodal analysis to understand causes, but also prognosis of disease, because, you know, I think that's really important to patients, is once they've got a disease, okay, I've got this, what are you going to do about it now? And as researchers, we're often not very good at doing that, but this might give us the opportunity to begin to do that.
Brilliant, thank you so much. I'm, in the interest of time, I'm just going to call our questions there. For any questions that we didn't have time to answer, we will follow up afterwards. There's a lot that were text answered too, so we'll also share the answers to those as well. I'd just like to say a massive thank you to our guest speakers and all of our panelists. I think what's clear is that there's so much data out there working together to bring it, to unite it and bring it together really is the way forward for impactful research that will ultimately benefit patients and everyone's lives, really, by teasing out the answers from all of the data that's that we have here in the UK. Thank you so much, everyone, and thank you to our audience for joining today. Hopefully see you next time.
Bye, guys.
Thanks very much. Thank you.